talking about ovarian hyperstimulation syndrome, OHSS. This syndrome typically occurs in patients taking luteinizing hormone for ovarian stimulation for in vitro fertilization. So it is an iatrogenic complication, and the patient will give classical history of taking luteinizing hormones. The patient will come at your clinic with severe abdominal pain, abdominal distension, and the pain may cause even nausea and vomiting to the patient. So why does it occurs? What is the pathophysiology behind it? So the pathophysiology is LH is already given for controlled ovarian stimulation, which increases oocyte retrieval success. But in 5% of cases, what happens is there occurs uncontrolled ovarian stimulation, which leads to the classic OHSS. So who are the patients which are at high risk of developing OHSS? So first risk factor is young age. Second risk factor is thin patient. So if you see a thin and young female coming at your clinic with abdominal distension, pain, and the history of LH injections, you know that it is OHSS even before imaging. Another risk factor is the female who has had background polycystic ovaries and background increased ovarian volume. Now, have you wondered why does the patient have pain and has the abdominal distension? So what happens is the hyperstimulated follicles in the ovary will release multiple vasoactive substances which will increase capillary permeability, and the intravascular fluid will leak into the pleural, pericardial, peritoneal spaces. So there will be abdominal distension, pleural effusion, pericardial effusion in these patients, and hence the abdominal distension and weak pulses. Now, with this background, when the patient will come to your end, you will order an USG as the first line of investigation. Now, what will you get to see on USG? On ultrasound, you will see bulky bilateral symmetrical ovaries. So the key word is bilateral symmetrical bulky. Because this is a systemic disease now, because the factors will work on both the ovaries simultaneously, that is why both the ovaries will be enlarged symmetrically. And what is the cutoff of enlargement? They will be enlarged more than 12 cm in size. Second typical feature will be, as the name suggests, hyperstimulation. So there will be multiple cysts giving a classical spoke wheel appearance. And third feature will be accumulation of fluid into spaces. Any of the three spaces will show fluid accumulation within those spaces. Now, so this is the basic thing what you will diagnose as a radiologist. Now, for more fine reporting, you should give grading of ovarian hyperstimulation syndrome. So the grading criteria is according to modified Golan classification for OHSS. It classifies OHSS into 5 grades. And lastly, what is the treatment of this condition? So there is no specific treatment prescribed. You just have to give the supportive treatment to the patient. IV fluids, painkillers, etc. Now, this is all about OHSS. But there is another catch in this. In rarest of rare cases, OHSS can occur spontaneously. That is without the history of LH injections, without the history of patient undergoing IVF. So who are at the risk of spontaneous OHSS? It occurs in the patients with hypothyroidism, because what happens is hypothyroidism leads to increased TSH, and TSH receptors are similar to ovarian LH-FSH receptors. So high TSH will act on ovaries and will lead to high estrogen release, and high estrogen will again do the same mechanism and increase the ovarian follicular sizes, will stimulate the ovary like the LH was stimulating. So just keep your thinking broad. Whenever you encounter a picture of bilaterally enlarged and symmetric ovaries along with accumulation of fluid in the spaces, you should call it an OHSS if the patient has the history, or even if the patient do not have the history of IVF, you should suspect OHSS because it can occur in patients with hypothyroidism too. That is all about OHSS. Thank you for watching.